Hi, my name is Marissa Harrigan, and I did my case study on lower limb amputations. Lower leg amputations are also known as BKA or below the knee amputation, and any amputation above the ankle is referred to as a major amputation, and these are performed by removing ischemic necrotic tissue or local unresectable tumors and is often a life-saving procedure. Lower limb amputations have three different types. There is a primary, which is performed without an attempt of limb salvage or saving the limb with a pre-existing treatment. There is secondary, which follows a failed attempt at revascularization or pre-existing treatment, which is failed limb salvage. And then there is a traumatic, which occurs at the time of injury, most likely in trauma in an accident or cause of loss of limb in war. There are many doctors associated with lower limb amputations. This is often performed by an orthopedic surgeon, but has common connections with general surgeons and a general orthopedic doctor. Vascular doctors could also be in connection with the patient has PVD, an oncologist if the patient has the amputation due to a tumor, and there is a recommended follow-up care with a primary care doctor. The use of physical therapists is also common for rehabilitative services. There is a long history of lower limb amputations. They are the oldest known surgically performed procedure. Hippocrates provided therapeutic amputations for vascular gangrene. The amputation was performed at the edge of the ischemic tissue, leaving the wound open to heal by allowing secondary intent to take over. There was many risks in the early days. The main risk was hemorrhage due to excessive bleeding, shock, or sepsis due to infection. Fortunately, there was no anesthesia used, so patients were often held down by assistants. They were given copious amounts of alcohol to calm them or put them to sleep, and the procedure was often performed while the patient was awake. Lower limb amputations today are about 30,000 to 40,000 procedures performed daily. They are the choice of treatment for severe trauma, vascular disease, and tumors. Surgery must be performed with the ability for the patient to comfortably wear a prosthetic after the surgery is done. And knee joint salvage will enhance the rehabilitative efforts and decrease any type of energy expenditure required for movement per patient. For post-surgery, the patient must be able to walk with, apply, and remove prosthetic on their own. They must care for the prosthetic and maintain the skin contact points comfortably. The patient must be aware of difficult terrain and uneven walking surfaces while adjusting to movements with the prosthetic. And the post-surgery treatment should include the surgeon, their primary care physician, a physical therapist, a prosthetic specialist, and possible social worker. Indications that require a lower limb amputation could be due to peripheral vascular disease or PVD. This is most common in elderly patients with diabetes mellitus. They experience peripheral nervous system issues that will progress into trophic ulcers and gangrene and osteomyelitis of the limb. They perform lower limb amputations for uncontrollable soft tissue or bone infections that had led to resting pains from muscle ischemia. Another reason for a lower limb amputation could be trauma. This often occurs in industrial or motor vehicle accidents, but also may occur in war. Comes from a high-grade open fracture that causes nerve injury, tissue loss, or ischemia, and unreconstructible neurovascular injury. Many times, limb salvage is attempted, but will result in an infection or a less functioning limb, which will cause doctors to lead to an amputation anyways. Another indication could be from a tumor. Malignant bone tumors are attempted to be removed with hope for no reoccurrence by surgery. Most limbs are able to be salvaged with an advanced technique for tumor removal, which requires no amputation. But in order for a limb to not be amputated, the risk of reoccurrence must be very low and the limb must be functionable. Results of a less functioning limb will often result in amputation. Another form of an indication is congenital limb deficiency, which often occurs in pediatric cases. This is often due to failure of limb development or function in a fetus. Not all require amputation. Most can be reconstructed through surgery, but that is with hope for a more functioning limb. Amputation is used when a prosthetic is more beneficial for patients. Outcomes of the amputation are to allow functional and emotional satisfaction to a healthier lifestyle. And the factors that will influence this perception of outcome is comfort of the residual limb or the remaining piece of the amputated leg, condition of the contralateral limb or the opposite leg, comfort, function, and appearance of the prosthetic, social factors, and the ability to still participate in recreational activities. Negative outcomes of possible lower limb amputations are post-traumatic stress disorder, which many war veterans will unfortunately have to deal with, sexual dysfunction, anxiety and depression, phantom limb or phantom limb pain, which is when the patient still feels as if the leg that was amputated is still there and feel pain from either trauma or post-surgery, and joint contracture, which leaves the range of motion from the proximal amputated limb joint to lose all of range of motion. Risks are also included, which are blood clots in the legs that may travel to the lungs, breathing problems, and bleeding. Medication and management of these patients could include pain medication, psychosis medication, like for PTSD, anxiety, and depression. Management could also include acupuncture, which assists with phantom limb and phantom limb pains, a physical therapist who gives therapy to adjust the prosthetics, and also a psychologist. They can help cope with anxiety, depression, and PTSD. They also assist with social concepts of losing a limb, like sexually and socially. For my case study, my patient's name is John. He is a 35-year-old male. He is a former war veteran who is no longer active due to a lower limb amputation after trauma in the field. John is an occasional smoker with stress or drinking. He drinks alcohol 1 or 2 nights a week, goes on a 10-minute walk daily with his dog to adjust to his prosthetic. He is 190.5 centimeters tall and weighs 78 kilograms. His systolic blood pressure is 124 millimeters of mercury, and his diastolic blood pressure is 74 millimeters of mercury. His total cholesterol is 183 milligrams per deciliter. His LDL value is 104 milligrams per deciliter. His HDL value is 51 milligrams per deciliter, and his fasting blood glucose level is 85 milligrams per deciliter. He has a prosthetic that he is comfortable walking in, but he would like to slowly introduce running. He has no daily use of medications except for taking ibuprofen for pain and an anxiety medication as needed for PTSD. He has no cardiovascular symptoms, but his father did die at 65 of a heart attack. His mother is living and healthy. For my risk stratification, his age, he is 35-year-old male. That is not a risk factor. His family history, his dad died at 65 of a heart attack. Since he is above 55 years of age, that is not a risk factor. Since John is a casual smoker, that is considered a risk factor because he has smoked within the last 6 months. He has a sedentary lifestyle because he walks only 10 minutes per day, which does not equate to 30 minutes 3 times a day, so that is considered a risk. He is obese. His obesity level occurs to BMI of 21.5 kilograms per meter. That is not a risk factor since it is not over 30. His hypertension level would be blood pressure of 124/74, which is also not a risk factor because his systolic blood pressure is not above 140 and his diastolic is not above 90. Dyslipidemia, his LDL value is 104 milligrams per deciliter and his HDL is 51 milligrams per deciliter. This is also not a risk value. His pre-diabetic is not a risk value because his fasting blood glucose level is 85 milligrams per deciliter. His risk group, since John has 2 risk factors, since he is a casual smoker and he has a possible sedentary lifestyle with daily activities being less than 30 minutes 3 times a week. This puts him at moderate risk. His medical examination is recommended before exercising at vigorous intensity. However, an exercise test is not required before exercising at moderate or vigorous intensity of exercise, and there is no physician required during moderate or vigorous exercise to supervise him. John's goal is to remain physically fit to his best ability. After leaving the Army, John was worried that he would lose his physique. He does not want to become obese and become sedentary, so he would like to maintain his muscle mass and aerobic fitness to his best ability given his condition of a lower limb amputation. For his exercise prescription, for his aerobic exercise, he should be working out 3 to 5 times a week. His intensity should be at a moderate intensity, which would refer to a 5 to 6 on a 0 to 10 RPE scale, or 50 to 80% on a heart rate reserve. The time should be at least 30 minutes, but could be up to 60 minutes. He could also do this in bouts of 10 minutes throughout the day. Types could be like an armagometer to help relieve him of stress on his lower limbs. With the prosthetic, he may walk on a treadmill, but avoid running until comfortable with the running prosthetic. Could also work out on a stationary bike by strapping in his one remaining limb. He could use a rower to also work his cardiovascular system, and he may swim if he is comfortable. For his resistance training, he could work out 2 to 3 days a week. However, since he has not done much resistance training since leaving the Army, it is best for him to start light at 40 to 50% of his 1 rep max and work up to moderate intensity to about 60 to 70% of his 1 rep max. The time should be about 8 to 10 exercises of major muscle groups with greater than or equal to 1 set of 10 to 15 reps each. The type could be resistance machines, stair climbing with the prosthetic, but he should avoid free weights due to instability of his joints. He may use strap-on weights for the amputated leg to maintain muscle mass in the upper thigh, but begin with body weight exercises if he is uneasy. He should maintain core and back strength training and may do one-leg balance exercises that will also enhance his core strength to maintain stability while living with one less limb. For his flexibility and balance prescription, he should be doing this 3 days a week, but daily is also recommended. He should stretch to feeling tightness or slight discomfort of muscle, hold each stretch for 30 to 60 seconds, and he could do any type of activity to increase flexibility. This could include Tai Chi, yoga, static stretching, or dynamic stretching. However, he should avoid ballistic movements. For his balance, it should be more so of a daily awareness. He should be aware he is not favoring his non-amputated leg, should watch out for popping out of his hip, and try to keep his hips even, especially while standing. Should also try to maintain even weight bearing for both legs. Modifications and special considerations for him. He should continue doing upper body workouts consistently with stationary exercises as in machines. He should be aware of restrictions with one limb available to manage the weight bearing of the lower limbs. His joint instability is common, especially proximal to the amputated area. More stationary activity should be performed until the patient is comfortable with larger movements, and he should avoid free weight bearing exercises as in squats that may require ultimate balance of his center of mass and gravity, which may be difficult with one true limb supporting the weight. In conclusion, amputee patients can progress physically in a similar fashion to non-amputee patients. Modifications are slim and individualized per patient depending on their level of comfort of the prosthetic. Not all patients will have access to a prosthetic, and exercise modifications could be extreme.